So what are simple cysts? They're circular or oval. There's no debris or septation in them. They're anechoic and they're homogeneous. Sorry, that's spelled wrong. And measure greater than 2 by 2 centimeters. Otherwise, if they're smaller, they may just be a normal follicle. And this is what I mean about practicing looking for those chocolate chip cookies, because if you see an older child that's in a follicular phase, you might see really pockmarked chocolate chip cookie appearance of their normal ovary. Compare that to this image. So here, we're still anchored in the pelvis. We can see our bladder at the top of the window here. And what we're noticing is a walled-off structure, but it's a little more complicated. We have hypoechoic and hyperechoic areas to it. We have sort of this heterogeneous content with septations. And there's a little bit of free fluid that you guys might be able to appreciate at the top of the image there. When we look at another image of similar style, you can see there's a bladder, but what's interesting about this is that this particular object that we're measuring is superior to the bladder in this view. So it's important to remember that with things being free moving within the pelvis, that you might see large masses superior to the bladder that may actually be connected to the reproductive tract. And so not to get sort of thrown out by that. So those two pictures were evidence of complicated cysts. They're heterogeneous, variable in appearance, and often have septations. They are increased in ovarian size, so what we say is greater than 4 centimeters in a postmenarchal female. They might be associated with free fluid, and really our role in point-of-care ultrasound is to say that there's a complex structure that's present there. What are we at risk of with a complex cyst in a large ovary? Torsion. And so how would we establish whether or not we have torsion? Yes. Great. So the answer to that is clinical picture. And the reason why is the history and physical examination are important. Some people do put Doppler flow, and you may find an ovary that has absence of flow, but remember that the ovary has 2 different blood supplies, and so as a result, that may not always be consistent. Much like any other type of torsion, you can also have torsion detorsion, which will change obviously your clinical picture, but also means you may not find sonographic findings. So really when we have a high suspicion of torsion, what we see is often a larger ovary for whatever reason. A complex cyst is often the case, and a clinical picture that fits with torsion. What our point-of-care ultrasound allows us to do, say, look, this patient has a higher likelihood ratio of having torsion because they've got this complex cyst present on their ovary. So what they really need is comprehensive imaging, likely with simultaneous gynecology consult, if there's really that classic history physical and the enlarged ovary. So kind of putting that whole clinical picture together and really making that determination that we want to facilitate this. We've had a few success stories here in the department of really being able to share that conversation with radiology and with gynecology and facilitate care in a more timely manner for these patients. Now, I'll speak very briefly on hemorrhagic cysts, only to say that these are often an unstable patient with adnexal tenderness or peritonitis. You may only see free fluid present in the abdomen, and again, because they're in such an emergent state, they may be hemodynamically unstable, you may not have a chance to really fill that bladder and get a beautiful look at the ovaries. That's ultimately not your goal when you're doing a point-of-care ultrasound in a patient that's unstable. You're really just trying to differentiate. And the talk next week will go through pregnancies, including ectopic pregnancies, and that's obviously going to be on your differential as well in a female of menstruating age who has significant pelvic pain and also happens to have unstable vitals. So we want to think about all these things together, but recognize you may not actually see a cystic ovary there. You may, but don't sort of hang your hat on that when you're making that differential, and really trust your clinical assessment for pushing that care forward. So large cysts are at risk for torsion. I mean, I would say that the increased likelihood ratio is worse in the larger cysts. Any ovary is at risk for torsion. So it's just really a spectrum. Is kind of how I would approach it. Okay, so our first case is a 16-year-old female. So she's had anuria and enuresis for greater than a day. She's had no fever, no vomiting, but feels full and bloated. And she has a palpable mass extending from her pelvis. So when this patient came into our walk-in side of the emergency department, this was the ultrasound that was seen. Okay, so it is a hematocolpos, you're absolutely right, which is an imperforate hymen causing the collection of menstrual blood within the uterine lining. What would have been one question we would have asked on history for a female that's 16 years old presenting with urinary retention? Or any 16-year-old female? Her last period. So her last period was 3 weeks ago. She has another finding on this ultrasound other than her hematocolpos. She has a bicornate uterus. So she had an imperforate hymen over one of her uteri, and the other one had proper shedding through a perforate hymen. So what she actually had was effectively a very deep bicornate uterus, and one of them was blocked off, but the other one allowed her to have normal menstruation, which is why it took a great deal of time for this particular thing to be diagnosed. So important in a hematocolpos history to be sure to ask that. Most patients with hematocolpos that we do see a few a year, tend not to have the initiation of menses, and that's obviously a big trigger to think about it. But remember that you may find the bicornate uterus, and this is a really interesting case for that reason. That makes sense? Can you guys see so the bladder's on the top, the imperforate uterus is the large circle, and then just over to our right of it, there's a little sort of side uterus. You guys appreciate that? Yeah. Here's another example of a hematocolpos. So again, it's really that thick muscular wall, very well circumscribed, and it's about anchoring this in your view with the bladder and your other organs around it. So they're usually hyperechoic and heterogeneous. They may have menses in the case of the bicornate uterus, but often have symptoms of constipation or urinary retention, or they can just present with frequent UTIs because of that incomplete voiding. Okay, our next case is a 7-year-old, 2 months of abdominal pain and vitally stable. Outside comprehensive ultrasound showed a bladder cyst, and so the parents came in to get some form of definitive management for this bladder cyst. So which of these two hypoechoic areas do you think is the bladder?
That's a tough question.
Yeah, it is a tough question.
Because the way you're asking it, I'm assuming the large one is the cyst.
Yes.
The small triangle one is the bladder.
What would the small one, what makes you think the small one is the bladder?
The wall is more triangular.
It's more trapezoidal, yeah, for sure. And the wall is sort of that kind of classic bladder angle. But the important thing to think about is that it could be either, right? It's really hard to tell in a very distended bladder that you're truly convinced of that. I think that's odds are what this patient had was the large cyst and then the smaller bladder because they'd probably just voided. But it's important to really anchor yourself in trying to identify those different factors because it can get tricky.
I don't think I wrote much
You didn't.
Detail about this case. So just one of those, like the difference between adult and peds things. A large cystic structure in the pelvis of a female. It's like a 6-year-old girl. Very unlikely to be a bladder cyst.
Yeah. Oh, I was getting to that.
That was the history. She was young and she had discomfort for a while, and the radiologist report from an outside ultrasound said bladder cyst.
Yeah. So it's very unlikely to be a bladder cyst, but what we're looking at from the cystic structure itself, what sort of, we can see it's hypoechoic, it's well circumscribed, there's not a lot of septations, there's not a lot of complications, it's significant in its size.